I am the professor of emergency medicine at Hopkins, and I direct the Center for Center of Excellence for Trauma and Emergencies at Aga Khan University in Pakistan. It is great to be on again this Monday morning here in Baltimore, and Monday afternoon in London, and evening in Pakistan. As you can see on your screens, today we are going to talk about a very important, interesting topic that we are all dealing with, the positivity, pragmatism, and proactivity. And we have with us two very experienced and right on the front line healthcare workers, emergency physicians, Professor Dr. Taj Hassan and Dr. Badar from Dr. Taj and Dr. Badar. They will introduce themselves. But before we go there, let me describe to you how we see the next 1 hour go. First, I will have our discussants introduce themselves. And then today we will have a few slides that Dr. Hassan would present and would frame what the discussion is going to be about. I'll request Dr. Badar to give a perspective from Pakistan, from a relatively low resource setting, and represent, bring reality to the discussion that we were going to have. And after that, as always, we would like to hear from all of you on emails. We will see those emails and we will share those questions with our discussants and get their feedback. So first of all, thank you, Dr. Taj Hassan, Dr. Badar, for participating today. So can I request Taj for you to introduce yourself, and then Badar?
Sure. Thank you very much. Thank you for the kind invitation to collaborate and contribute to today. My name is Taj Hassan. I'm a consultant in emergency medicine here in the UK, in Leeds. For those of you who don't know where Leeds is, it's in the north of England. It's a bit colder than most other places. And I've also previously been president of the Royal College, and I'm also delighted to be able to contribute actively to Pakistan Society of Emergency Medicine on its international committee. That's about me in general. Thank you.
Dr. Badar?
So, Assalamu alaikum and good morning, Dr. Junaid. I'm Dr. Badar Afzal. I'm the assistant professor in the Department of Emergency Medicine at Aga Khan University Hospital, Karachi. And I'm also the program director of Emergency Medicine Residency Program, which is the largest public and private sector emergency medicine residency program in Pakistan. And we are one of the pioneers to establish and initiate this process of training the emergency physician in Pakistan. I'm also the service line chief, which is to say that I am heading the clinical management administrative processes of emergency medicine in Aga Khan University Hospital. And I've been associated with the hospital for the last more than 15 years or so. And it's a long association. It's my second home. And we are, you rightly said, we are at the forefront of this pandemic, braving and, facing the challenge. So that's about it from my side.
Thank you both for the introduction. Taj, can you take us through what we are going to talk about and frame it for the discussion, please?
Okay, thank you very much. So I think we've all been, I suppose, overwhelmed really by the scale of the challenge that has faced us over the past 2 or 3 months. It's gone from a small localized event in Wuhan through to a pandemic that none of us have ever seen in our lives because none of us was alive in 1918 for the last world pandemic. And I think one of the things that's really struck me is that we have had such a phenomenal global coordination of clinical guidelines, of things to do and activities and therapies that could potentially impact on the COVID-19 virus. But what is undoubtedly also important is to consider how we as individuals and our teams function within emergency department settings. And so these were sort of three, I suppose, factors that I think are really important in the broader human factors consideration of how we behave in these settings. The concept of positivity, pragmatism, and proactivity in how we behave. If I click to the first slide, and really it's a complicated slide in one sense, but if you look at the green things, these are all the things that we set up structurally for our departments. Hopefully but it varies a lot around the world. And I think actually one of the things about COVID-19 is it's been a great leveler, whether you live in a resource-intense environment like the United States or even the United Kingdom. Access to staff testing strategies has been pretty woeful. And then things like zoning your emergency department, that seems to, most places seem to have been able to do that. PPE is a big deal, and again, huge scarcity. We're presently struggling with this in the UK, but I can only imagine what it's like in other low middle income countries where it's such a major challenge. Therapies, I'm not going to talk about a lot, but we can come back to it. But these are all structural things. And then over the other side, we also try and build sort of academic rigor around how we train and educate our staff, situation reports and data collection, how we structure our hospital and system flows to help us. At the heart of it are the key issues of how we communicate, hand over, do safety huddles, and connect with our wider hospital team to engage and optimize the care for our patients and our staff. And really across all of those parameters, as leaders, as we all are at various levels, our need to maintain a positive approach, to be proactive in each of those domains about what is being done, what can be delivered, and lastly, pragmatism around if we can't deliver it, how can we as the ingenious people that we are as human beings find a way to tailor our resources and our capacity to meet this demand. So I'm sure we'll come back to it. Dr. Badar and others will want to comment upon their own mental models around this, but these are the things that struck me as being key. And then the second slide is really very much about getting the best out of your team. And we know when we are trying to deliver programs or trying to address challenges, it's all about communication. Whether it's the communication that comes in via floods of emails, which isn't as impactful, whether it's your WhatsApp group that you set up, whether it's just hard copies that you pin up on your walls, laminated, of course, or whether it's the power of face-to-face discussion and being able to galvanize your team to tell them the key things. And communication strategies are so utterly vital at this key time in how we maintain positivity for our teams and highlight the things that they really need to proactively manage. The second thing in human factors, obviously people talk a lot about non-technical skills and simulation, but also how we either formally educate people as we go along or support them through training and education, either on a daily basis or a weekly basis as we move through this pandemic. And again, I'm sure there are a lot of people on the call that will be able to exchange good ideas about the frameworks that you can practically use to keep your team engaged. Our teams rely heavily on us, not only to lead them, but also to support them. We will all do things that are wrong in hindsight, and it's important to learn those lessons, to debrief well, and highlight the positive things, the things that went well, and those that we need to learn for next time. And the last thing, of course, is engaging and empowering the wider system and the rest of the hospital. Pandemics, well, this pandemic, this is the first in my lifetime, is about everybody stepping up to the plate and helping. And I'm sure in many systems this is happening, but again, the ability to connect people together to get the very best out of the whole hospital in order to deal with the challenge. And my last slide really tries to bring all of that together for you into sort of 3 actions. And the positivity is about finding ways before you come to arrive at work, before your shift. How do you energize yourself? How do you connect to the people around you to help support you, whether that's mentally, physically, spiritually? And how do you care for yourself during the shift? Regular hydration, eating, again, debriefs. And what do you do post-shift? How do you make sure that you clean down before you get home, that you clean down when you get home? How do you de-stress? And how do you spend time with family, either virtually or physically, to recharge your batteries? So these are key things that you need to be aware of, and we all have different strategies, but I hope that the slide highlights ways in which that mental model that you can build. Secondly is proactivity, and I highlighted earlier that everywhere you work, I think there are very few places that have the right PPE, and we are all sort of lumbered by the fact that there is a limitation of adequate PPE. How do you make sure that you have good team handovers that are structured, that highlight the key points, and regular safety huddles to make sure that people are being well disciplined in terms of PPE with their buddies and caring for each other? And that you're also then ensuring flow out of the emergency department in discussions with your administrators and others. And the pragmatism, well, the pragmatism again is linked to PPE. If you don't have enough, how do you make it last? How do you find ways to support yourself and your team and your buddy? The staffing strategies that you have, you may find you only have enough staff that the staff have to work in the hot zone for an entire 12-hour period, but maybe you can find ways to rotate them into a cold zone or a warm zone. Maybe you can find ways to give them regular breaks because it's essential, otherwise they will make mistakes. And those mistakes will usually be that they will not care for themselves, which puts them at risk. And lastly, which is a really tricky issue, is AGP events, whether you're putting people on NIV or having to do intubation, and how can you find ways to optimize the way you protect yourself and your staff, and ideally make sure that those AGP events occur in appropriate environments, which may actually be remote from the emergency department. So those are the 3 things that I really just wanted to talk about. I hope I haven't taken too much time. Thank you.
This is really great, Taj. I think it really nicely positions the discussion for the next 45 minutes. What I would like to do before I request Dr. Badar to comment and talk about how she's seeing the personal mental models in her practice, in her situation, I'd like to just show all of you guys the email address where you can ask questions. So if Taj, you can uh, unshare your screen, and I can maybe share my screen so that we can. So this is this is the presentation that Taj you gave, you giving, and this was your. So before I move forward with Dr. Badar, this is the email address that you can write to us, and we will get people engaged, and we'll get a response from the discussants. Coming back to you, Dr. Badar, how do you feel about what was presented here and how you're addressing some of these issues? I'm sure they're very similar to what you're facing. Which amongst these are most challenging for you, and how you're responding to those?
So thank you so much, Dr. Junaid, for inviting me in this session, and Dr. Taj for bringing the mental model in front of us, so we can relate and can share our own experiences. So as far as my experience is concerned and my mental model is concerned, it's more or less the same. The first challenge that I faced personally, and I'm sure many of us in this field have must have experienced, that is the acceptance of the fact that our life is changing. It has to change. It is not the normal routine life that we have always been dealing with, and doing whatever we're doing in a routine process has changed, because this COVID pandemic has led to many unique challenges for individuals, for teams, and for the systems. Once you have broken that inertia that you have to change, and this is the main turning point for me, that you have to accept the fact that disease is there, it's real, and it has to stay, and is going to stay here. Then you start building up your defense. What is the most important thing for you to do? What is the priority? For me, the model is like, you have to change the structure, you have to change the workflow, and you have to change the mindset of your team and prepare them for the worst that yet to come in Pakistan, at least. So for structural changes, taking all the things, positivity, proactivity, pragmatism, I think the most important thing that helped me is to involve my team, involve the team as, because I think individually you can't do anything. It's the teamwork, and you have to change the structure within the ED, the process flows within the ED. And then, the other challenge is that the load of information that we had, it's information overload everywhere, and you have to retrieve that thing which is concern you most, and it has to be authentic. So for the structural changes, the redesign changing, we change the model of whole emergency. We had discussion, we separated the triages, and then we have move out the whole triage system outside the main ED. Then we have to divide ED into various portions, just like Dr. Taj said, hot and warm zone, we call it COVID and non-COVID zones. And we have to define the teams over there, the workflow process. They has to be separated, the healthcare workers, the teams, and the patients, they have to be differentiated between the two groups. For me, the three main challenges were, we have to keep the doors of hospital and ED open for patients up to a certain capacity. You have to make sure that your team is, including myself, is safe to provide care to these patients. And the third most important challenge for me is to make sure that the right patient is admitted to the right place. If you're admitting a single patient in the wrong place, a positive patient in a regular room is, or bay is, its implications are huge. So that was my model. I had to be, have to have a very clear focus to do this thing, to deal with this thing. So for that, the other challenges were the communication among our team to uh, inform the people who are on ground, the person who are working over there in the emergency, the information that I'm getting, and communicate, to educate the teams, the residents, the staff who are working there into the new paradigm that we have shifted to take care of themselves first and then take care of the patients. The other challenge was PPE. It was not the supply or availability, thankfully, in institution which we are working. It's the use, it's the mindset, it's the change in the behavior, the attitude, and the practice. Because I think if you have loads and loads of best possible PPE, if you don't change the attitude or mindset and discipline your staff and doctors to behave in a certain way, they won't, affect that. They will be at high risk. So these are the main challenges. And then you educate for the treatment. You have to change the schedules. You have to have a backup team for, in order to, have a backup if your team gets exposed. You have to reduce the timings of your shifts. That is the thing which are the challenges for me and my team. And last thing is the communication between the workforce, my team, and the hierarchy, the institution's leadership, what they are working and what they are planning to safeguard us, to accommodate more patients, and to communicate that thing to our team. That is the thing that we faced the challenges, and with the teamwork and with the solutions we bracing up right now.
This is, thank you. Thank you for summarizing your thoughts on it. Again, for those who are listening to us, I put in the email address for the questions, coe.te@aku.edu. Please feel free to share your questions with us. I'd like to ask Taj the question around the positivity and your personal practice. Given everything that's happening, you are seeing patients in the ED, and those of us who are seeing patients are realizing how different the experience is given the presentation and rapid deterioration in many of these patients. How do you maintain your positivity? What do you do before you come to work and during your shift and afterwards?
Thank you. So I think we have to accept first and foremost that this is the biggest challenge we have ever faced, and if we do not care for ourselves in that widest of senses, then we will not be able to function well, and will not be good for our to be able to care for our teams and then ultimately the patients. So I think caring for yourself includes eating healthily, exercising regularly, whatever form of exercise you practically can do in the context of a lockdown. And I think trying to maintain that frame, because I think at the heart of it, we're all anxious in our own ways. We look at headlines of healthcare workers who've been infected, and then sadly a small proportion who've done very badly. But I think you have to set that in that context of it's a matter of proportionality. You're just as likely to get it anywhere, but actually being able to be disciplined, be positive, stay healthy, and then doing what you trained for. And I think when you get to work, to follow a routine in terms of how you structure engaging with your team at handover, the key things that you tell them, and then maintaining that momentum through the shift, depending upon the area that you're working in. I don't know what it's like for other colleagues, but as the senior team leader, I tend to base myself in the hot zone, and then try and get some short periods to come out. But actually, of course, that burns up PPE. So I think you have to be really careful about where you work, how much PPE you might burn, and then how you communicate with the other areas of the department. And I think then after your shift, to maintain positivity, I think you have to be kind to yourself, and you have to give yourself time to rest and recover and recuperate. And so we will all have different strategies, but I think if you bear all those things in mind about caring for yourself and therefore caring for your team and those around you, that will hold you in good stead.
Thank you. For Badar, you mentioned multiple challenges. One of the things was managing the staff and physicians and nurses. I know it's a difficult question. You have some people, we all have some people who are very anxious to the level that it may impair their performance. And then there's other extreme where people are not concerned at all. And you're worried about their exposure and through them, the exposure of other staff and patients. What's been your strategy? How have you dealt with that?
So thank you for the question, Dr. Junaid. And yes, it is a difficult question. Dealing with all sorts of team members or types of personality, it's a huge challenge for me, especially when you know that there's not enough time to keep on, guiding them, educating them. But then again, having said that, I try to do the same similar thing, and guiding, engaging, their alleviating fear for those who are very anxious, asking about them what's the biggest fear that they have. And surprisingly, they're not afraid for themselves. They're afraid of taking the infection to their family, to their loved ones. That is the main thing that, surprised me. The morals of my team, both the physician and nurse, is surprisingly very high. And it's a pleasant surprise, by the way. And for those who really don't care, I think it's a very small number of people who are like that. But again, when you engage them and you tell them about the consequences of not following the things that they're supposed to, which are recommended, that make a difference. That made a difference actually. And it's not about I am doing that thing, but my team members also, as I initially said, that the teamwork. So if someone is not listening to me or not understanding that, my teammates, my senior management, my faculty, is there to guide them. And I've seen changes in their mindset, their understanding, and their insight. That is a very positive thing. And the real hit was surprisingly very realistic and frank, that when we had exposure of a first patient, and almost 20 of my staff and physician were exposed, despite the fact that they were wearing PPE, and the fear of being exposed was so great that I had to cut down my roster drastically. And that example, although luckily none of them came out to be positive, they went to quarantine, and there's staff shortage, doctor shortage. They realize that this is something which is real. They have to take care of themselves. They have to follow. They have to be disciplined. That's how I, dealt with it. Regular education, small group discussions, huddles, sharing the information through various media, and engaging the specific groups like infection control, infectious diseases, and the other people around the stakeholders. And this regular information sharing, guidance, that helped a lot actually.
Looks like it's both the fear of seeing actually exposure and its consequences, at the same time, positive communication and constant communication. I have a few questions here. I'm going to read this for you. First question is from Dr. Murad Khan. And the question is, in UK, people are asked to stay at home and contact NHS either online or telephone first. They are then advised whether to present to the hospital or not. Now in Pakistan, given the fact that Pakistan has different health system, there's private, government, NGOs, how are EDs, especially AKUH, dealing with this without, having a pre-triage happening? I guess, Badar, how are you handling this reality?
So the matter of fact is that initially we started having screening as well as testing the people who are coming to have this done from the community health center perspective. They used to do it, and the spillover was taken care of by my team. They were screened, sometimes they were tested. Most of them, following the NIH guidelines, the patient who are screened positive, they were asked to self-quarantine, get the test done, and get the follow-up done. The situation became overwhelming, so we temporarily stopped the testing. We are still doing this screening. We are still involving and informing the government. And then we are, asking them to get their test done from the other government designated areas and get them quarantined. That is the strategy that we are following. Initially, the plan was to separate the testing site from outside from the main campus. Then again, we are trying to, get the test done over here in the main campus. That is the process that we are following right now.
So did you feel that you were getting a lot more patients who did not come to the hospital, did not need to be in the hospital?
Yeah.
Yeah. Okay.
Yes, but the thing that you have to counsel them, okay, you don't have to come. You have to follow certain guidelines that we've been sharing with them, and then report if the symptoms are getting worse. So that is the strategy that we're following right now. Okay. We have seen a lot of worried well, actually. Now, for the last 1 week, the situation is changing. We are seeing a lot of sick patients who require admissions in the hospital, in the special care ICU. So that is the trend that is changing in terms of patient population.
Okay. I have a question from Dr. Munawar Khurshid. I know him very well. You know him very well. He's asking, how did he's asking about patient flow and what are your strategies in terms of getting inpatient patient beds so you don't have patients staying in the emergency department? What are the strategies for you these days?
So the main thing that we change in the design is, Dr. Junaid, is to move the triage out of the main ED. So we have two tents outside ED. These are called the triage, sorting out fans or filter triaging. And from there, the nurses triage them into two different types of patients, either suspected or confirmed COVID or non-COVID. Then there is patients who are suspected. They have designated area in the ED, which are the respiratory COVID unit, and we are in the phase of developing the non-respiratory area for non-respiratory COVID patients. So for the patient who are walking, with stable patient, category P3 patients who are here to get admitted and who require some admissions, some sort of treatment, they're admitted directly from the filter triage. The ID team and the bed management team is informed. We have a capacity of around 40 beds for such patients, and we are admitting them regularly. For the patient who are more sicker and who require emergency intervention, they are taken into the separate area, which is known as respiratory COVID units, and they are being managed over there. These are the patients who are mostly suspected because, as I told you before, they don't have the testing capacity which is required to test them. So these are being tested within the ED, And the reporting time is unfortunately is 8 to sometimes 10 hours. But we don't wait for the result, and we admit them into a separate cohorted area within the hospital for such patients. These are equity convertible beds in the hospital, separated, isolated rooms. So these patients get admitted over there. That is the main change in the design of ED and the workflow process.
Thank you. Another question from Dr. Murad, and maybe Taj, you can help us with this. If proper PPE is not available, what is the healthcare responsibility in terms of attending to a COVID patient from an ethical point of view? And I'm sure you have an easy answer for that.
Yeah, absolutely. I think it's incredibly difficult, isn't it? We have trained all our lives and are hardwired to care for our patients. But at the heart of it, we also know that we need to care for ourselves, for all the other patients who might benefit from our care if we were untowardly made ill. So I think depending upon where you are, so, you know, here I am in a first world country, 6th largest economy in the world, and in my hospital in Leeds, which is the 2nd busiest major trauma center in the UK, we have just had a WhatsApp call that we only have adequate PPE for the next 48 hours because of the burn rate of our PPE. So you use a variety of different strategies. If you've not been fit tested, or if your fit testing has failed and you haven't got the right masks, you begin to look first and foremost at the amount of PPE that you're burning, and try and keep in reserve the PPE that is going to be most required for the high risk events, the AGP events, and make sure that for those events you will have good PPE. For the rest of the cases, you might use tactics such as making sure that once you're in the hot zone, you stay there, so therefore you only use one kit for as long as possible. And thirdly, then if you only have a surgical mask, etc., that you're using that in lower risk patients. We know that if a patient collapses with a cardiac arrest where they were likely to have COVID, their likelihood of survival is extraordinarily remote. And I think certainly our policies in our departments is to get them into the resuscitation room, where one would hope there is good PPE, and that you're extremely careful in terms of how far you go in terms of making sure that it's not a futile event, and where your team is likely to be put at risk for that futile event. So I think it's a matter of, at the heart, it's a long way around of saying, ethically, we're bound to try and help, but we're bound to try and help in a way in which it's safe for ourselves and our team. And I think by stratifying patients, that's important. And by stratifying the interventions that you perform, that's also important. And I think in the context of the present pandemic, these are all shades of grey that we try and do the best we can in the circumstances.
Yeah, thank you. I have a couple of related questions. Moed is asking Taj, what specific measures are taken in UK or the hospital that you work in to prevent individual breakdown or compassion fatigue among healthcare workers directly facing the patient surge in the pandemic? And Taj, I'd like you to respond, but Badar, also I'd like you to respond as well in your setting, because there's a similar question from another about the local Pakistani scenario.
Dr. Badar, do you want to go first?
Okay, so it's a very good question, a very relevant one. And that's what we are, luckily we are not being hit by the wave right now, but it has started to show in the team that we are dealing with, the patients who are there directly involved in the patient care. It's just the junior person and as well as the faculty who are directly involved in that hot or COVID area. The patients are dying, and you try to, people reflexly as ED physician going to resuscitate these patients with the same zeal and vigor that they do for the non-COVID patient, which is for me is a bit concerning, because I think the main focus for me right now is to save them first, the healthcare provider, and then we are patient-centric. We have always been patient-centric, but the situation has flipped. The safety of healthcare provider comes first. And when you are done with this crash or CPR or crash situation, the after effect of that is, the after effects are huge actually. The implications are huge. They are depressed, they are fearful, they feel that they have lost the battle. So for dealing with such situation, I guess mere counseling by the mentor or faculty is not enough. We have to have a structured program, and we need to seek help from the departments who can deal with it. We have a group of psychiatrists within the institution who have developed the helpline, and they are dealing with the situation. They are counseling the employees, not only the physician, but the staff who are stressed out. Positive notes, positive counseling, end of shift and before shift discussions and huddle are the few steps that are necessary to deal with such a situation. That's what we are doing, and that's what we are trying in our institution.
Okay, so very similar from the UK experience. I think the presentation I showed at the beginning talked about, highlighted three things, in preparation for the surge. We're just getting busy now in the last few days, week or so. We've done a lot of preparation, we've done a lot of planning, we've done a lot of education. And I think that gives people a certain level of confidence and assurance. But I think education only goes so far. The second key thing is how we communicate. So as I highlighted, the stuff that you send through email or the stuff that you do on WhatsApp, but there is nothing more powerful than being a leader and having your small core team and giving them good handover and showing that you care for them, showing that you want them to have regular breaks, showing good empathy and support during those times. And then, of course, when things get tough and, you end up having to perhaps, resuscitate people and in the department and making sure that you find even 1 minute or 2 minutes at the end to debrief, to tell the team how well they did in the circumstances. Just 2 or 3 good things, possibly one thing that you might want to do better next time. But really just reinforcing good behaviors is really, really important. And then I think at the end of all of that, you will know, all of you, that, a team of whatever, 20, 30, 40, 100, there's a whole variety of different personalities and they portray their anxieties and worries in different ways. And they will have their own small groups of friends. But I think if departmentally you have a strong culture of support, that's very powerful. And in the long term, I don't think any of us know what the mental impact of this pandemic will be on all of us. But I think if we support each other throughout this process and just reinforce that we've done our best, then I think, that will hold us in good stead.
Great. Coming to the more operational side on, I guess, the proactivity, and pragmatism. There's a question from Dr. Yasir Khatak. He's asking to Taj, I think what diversion strategies have you applied, if at all, to manage the flow through ED? That is for other specialties like GYN, PEDS, minor presentations. Do you guys have a setup where these patients will be directly sent to the relevant specialties rather than waiting in the ED?
Yeah, so we've had a good system response within our hospital. So all of our minor injuries work we've diverted to another part of the hospital, and our orthopedic surgeons have taken that on, which is very good of them. Our pediatric patients who are non-COVID presentations have been taken on by the pediatricians, which is good. One of the major concerns actually in the UK, I don't know whether this is presenting in Pakistan yet, but or will, but there has been a massive fall off in attendances. So all the patients that were normally our normal attenders or query stroke or anything, they're not coming. Nobody wants to come to the hospital. So so our attendances have gone down by 60%, 70%, which is remarkable. And so we're trying to push out now and saying, actually, if you have got something wrong with you, if you're really worried, please come to ED, which I didn't think again in my working life I would be saying to patients. So I think sharing it out is good, but I think the bigger worry is that there's a whole pile of patients who are actually potentially going to come to harm because they had something bad or they didn't come to hospital.
Raj, we have a similar situation over here in Pakistan. So the number of patients who are non-COVID with acute emergencies is very low. But still, we have managed to see these patients who are really, really bad. One of the factors could be because of the lockdown of the city for the last 3 weeks. We are seeing certain patients with acute stroke, MI, and we have to, really clear them up from the COVID suspicion. And if they are cleared, then the teams take them immediately because the census of hospital is also low. So the similar situation is we're facing over here.
Yeah. I mean, our incidence of major trauma has gone down by 80, 90%. But of course, that's because everybody's in lockdown, stuck in their homes. They fall downstairs. Yeah. We get people falling downstairs.
Yeah, yeah.
One of the things that I wanted to also address is the issue of labeling COVID and its impact on patient care. And, in my practice, I've seen that patients with a minor cough or fever, and they have something else that could potentially be wrong with them. They are, because the testing takes a long time, the care may be delayed. Have you experienced that, and have you thought about any interventions to address those?
So in the UK, I mean, our turnaround testing is really slow. At the moment in my institution, it's 24 hours. You're treating patients empirically, you're going on inflammatory markers, and that's about all we can do. Our biggest testing concern is also for our staff, because we're 10 or 20% down on staff. And so we want to get them back on the front lines. So there's a push to get testing done more quickly. But in terms of therapeutic interventions, obviously, as you know, there isn't much apart from organ support. Yeah, I don't know if that answers your question.
Yeah, yeah. Badar, do you have the same sense that I have, or you don't feel that the care of other patients is getting hampered?
No, it is absolutely the case, Dr. Jain, but worse than that. The COVID become a stigma for the people and the society. So what trend that we are seeing right now over here is that people are starting hiding their symptoms, uh, hiding their history of travel or being with someone who has had COVID. So it's very, very difficult for us to, have, we keep on filtering these patients. We keep on screening these patients, even if the first screening is negative and they're taken into the non-COVID area. Even then, you have to, keep on asking. And at the end of the day, you just, after a few hours, you get to know that there is some suspicion and they should be taken to the separate area. And that is the reason people are not coming to hospital or hiding, and which lead to a delay in their treatment. In ED, we are trying to provide as much care as possible because of the redesigning and the uh, workflow process. But I'm not sure about the other hospital emergencies, how they are treating them. Patients who are coming to clinics, they have a screening site outside, and if they are screened positive, they're not being taken in the clinic. That is something which I believe that is very concerning. I have received few patients who are being turned down by various hospitals having acute MI. They came over here, we took them, and they died in front of us because there was a late presentation. So we are seeing a lot of such patients in our ED.
Hmm. We are almost at the end of the session, and I have a couple of questions, and I think they sort of I can combine them. Maliha has asked a question. Aisha Abbasi has asked a question. The How do you see the future as leaders in emergency care? What's going to happen in next few weeks, few months, a year from now? Uh, how will it change, and how prepared are we for that change? Taj, you want to take this first?
Yeah, sure. So I think we should regard this very much as a marathon and not a sprint. This is not about relieving lockdown in a few weeks. I know the President of the United States is very keen on things like that, but I think most, I was going to say sane people, most scientific community would say that this is going to take a year or more. The exit strategy is a vaccine or some antiviral therapeutic intervention, which seems less likely. The vaccine is 12 to 18 months away. We will need to think hard about how we create, for me, first and foremost, resilient PPE supply lines. Secondly, how we reinforce good behaviors amongst our teams and we give them time off to recover and recuperate so they come back to us regularly. And thirdly, how we cope with ensuring that the rest of the hospital and community is supporting us during this time. I think the WHO today talked about the fact that more and more of us will have to get used to walking around with masks on our faces in the community. That's an extraordinary statement, but it just shows how we will need to normalize living in the age of COVID.
Thanks, Taj. Badar?
So as I said earlier, Dr. Junaid, the acceptance and the realization that the disease is here and it's here to stay, I'm not sure how long. This is a new normal for us, for all of us. So for new normal, we have to change our lifestyle and maybe permanently. We have to, as emergency physician, we have to, redesign the EDs for future as well, redesign the workflow and follow that. As far as PPE are concerned, I agree with Dr. Taj that we have to have, some sort of the arrangement for having a constant supply and a more resilient one. We have to discipline our team and juniors to follow that, the routine, the standards, the new standard and new routine. And, to make sure that the other people, the non-COVID patients get the treatment, right treatment at right time. That is the main thing.
Great. Well, thank you. Thank you both for addressing this very complex set of issues, from very generic, broad to very specific ones. I think we can end on some positive note that there are countries who are doing better today than they were a few days ago. And we know a lot more today about the disease than we knew a week ago, and hopefully a week from now we will have a lot more in terms of understanding on how to manage and treat this condition. Those of you who are online, our next session is going to be next Monday. It's going to be on a very clinical topic. It's going to be on critical care of these patients, and especially the event management. So please join us. And with that, I'd like to thank my team in Pakistan, Talha and the IT team, as well as the team at Hopkins, Priyanka and Garisco, who helped organize these. And again, thank you both, Dr. Badar and Dr. Taj, for being part of this. Appreciate it.
Thank you.
Thank you.
Sure.
Take care and stay safe. Bye-bye.
Yeah. Bye.
Bye-bye.